Good afternoon. Wonderful to see you all. It's my great pleasure to welcome you at the occasion of the 174th Qatar Lecture. My name is Bert Hofman. Hold your fire, hold your fire. The Qatar Lecture has been delivered once or twice a year since 1912, under the terms of the bequest of John Clarence Qatar. You see it all in here. It has been, since 1912, in the sense, the oldest lecture in epidemiology and prevention. John Clarence Qatar was a graduate of Harvard Medical School in 1912. This was a combined school. But since 1912, it was done under the auspices of the Department of Epidemiology, first in the medical school and since 1944 in the School of Public Health. So we are very proud to do this still. Today's Qatar lecturer, 174, is Dr. Karl Lauterbach. Dr. Lauterbach is a clinical epidemiologist. That's why he's here. Otherwise, in his current position as Federal Minister of Health in Germany, I would have, addressed him as Your Excellency, Karl, but I don't do that, no, because he's an epidemiologist. 1989, MD, medical degree in Düsseldorf in Northern Westphalia in Germany. 1995, a Doctor of Science here at the Harvard School of Public Health. 1998, you started as a professor and director of clinical epidemiology in Cologne, in Germany. In 2005, you became a member, Dr. Lauterbach, of the German Parliament, the Bundestag, and since a year and a week, approximately, I would think, you are the Federal Minister of Health. It is really a great pleasure, and I may say an honor to have you here to speak about evidence-based policymaking. Dr. Karl Lauterbach.
Well, dear Dr. Hofman, dear Bert, John, colleagues, friends, it's a great honor for me to be able to speak to you today, and I'm also very pleased that I see so many students here, because when I entered Harvard School of Public Health more than 30 years ago, this was not an easy decision at that time. I initially wanted to become a surgeon, cardiothoracic surgeon, and when I came from Texas at that time, I asked my that time mentor, David Cohen, to write me a letter of recommendation to study epidemiology and clinical epidemiology, and also to go to Harvard, to go to Boston. And he did so, but he said, this is a double mistake. First of all, that I would waste my minor talent for a research topic like epidemiology and not pursue a clinical career is already a first mistake. And to leave Texas and then go to Harvard or Boston is an even worse mistake. So I remember having arrived here, but even at that time, I felt a tension between, let's say, helping individual patients or doing individual research projects or making that research available to more patients. And that had occurred to me already when I was in Texas. For example, when I was in the operating room and we would work on 10 patients that day, at the end of the day, I would be able to basically come to the conclusion that 8 or 9 of those patients were in the operating theater with diseases or injuries that could have been prevented. That was actually how I came to make up my mind to leave surgery and to move forward for epidemiology here. Most of what we did was preventable. Obviously, when I asked for that letter of recommendation, I didn't stress that point. But once here, the tension was still felt because epidemiology is also cutting-edge science, and we were moving forward. My first advisor here was Walter Willett, but there was, again, this tension. We know so much, and so little gets worked into practice. So little of what we know is, in one way or another, quickly implemented in either policy decisions or politics. So therefore, from the very beginning of my career, I have always felt the tension between the beauty of science, but on the other hand, the necessity to bring science into practice. And I've become ever more, let's say, ambitious and ever more interested in making what we know available for more people rather than conducting primary research myself. So therefore, I stepped into, let's say, academia, and from academia, I stepped into advising politicians, and later I went into politics itself. And the clear-cut agenda, the hidden agenda which I have today, so I hope no one recognizes this hidden agenda today, but my hidden agenda is that I want to convince people who are in this room to consider that path for themselves. And I will try to show regions where we know the science, but we never implement it, and where you have to know the science in order to implement it, but where we need better policy making, where we need better politics. So my talk here today is about, let's say, how I tried to improve evidence-based policy making, the title of my topic. And I start, first of all, when I entered policy making, we were still working on small problems. For example, when I was advisor to that time Chancellor Gerhard Schröder, we knew that in Germany, length of stay in hospitals is longer than medically necessary and was longer than in other European countries. So what we actually did in terms of, let's say, evidence-based policy making, we introduced a DRG system in order to shorten length of stay. And exactly that happened. So length of stay shortened extensively. We, for example, in certain procedures, recognize if there is not enough experience with the procedure, the quality of the surgery goes down and more people die. This is, for example, the case for pancreatic cancer surgery or Whipple procedures. So what we did, we basically enacted minimum volume laws. Therefore, the procedures should only be built if you do more than a certain minimum amount. Or, for example, what we did know, that in Germany, when it comes to, let's say, diabetes treatment, we were over-treating the diabetes, so we were basically lowering HbA1c to the lowest possible level, but we were under-treating with respect to the blood pressure control of those patients. And from an evidence-based perspective, blood pressure control for these patients is way more, strict blood pressure control for these patients is way more important than over-strict blood glucose control. So we came up with programs which we called disease management programs, and they are now implemented in all German primary care offices, where the kind of disease management which is evidence-based has to be documented and is partially considered in the payment issues. So I started in doing exactly what I learned here, following the iron rule: for a man with a hammer in his hand, everything looks like a nail. So we always try to, let's say, bring in line newer evidence-based concepts with, let's say, what we know, and that was for quite some time was successful. Not all was successful. For example, we now come up with a different policy how we will in the future reimburse hospitals. So we will move forward beyond DRGs, but again, we will do this on based of evidence-based policy-making rules. My talk today will focus on 3 areas where we will not be successful if there is not a major change how we approach things. So what I have done in the past as, let's say, a policymaker, a member of parliament, now as a minister, I have worked on very specific problems where the science is known, where the policy is known that we need, and we bring that into place. But today I focus on 3 major problems where the simple rules of what we have done in the past simply do not work, and where the gap between what we know and the gap, and what we have to do, the gap between knowing and doing is ever becoming bigger, and these three issues are aging, climate change, and environmental. So I'll start with aging. In most industrialized countries, the challenge of the baby boomer generation aging is vastly under-recognized, vastly under-recognized. You basically can group regions in two regions, Africa and all other regions. And all other regions have one problem, that those people aged 60 and up, that group is growing. The group younger is either stable or is even becoming smaller. So therefore, in the healthcare sector, but also in the retirement sector, we will have major challenges, unbelievable challenges. Currently, the baby boomer generation, which you do see here, is at the height of its productivity and is also reasonably healthy. 50% of the members of the baby boomer generation already do have at least one chronic condition, but most of them do not have the complications of this chronic condition, and they do not have many chronic conditions. And they are therefore at the height of their productivity, and they are reasonably healthy. In a couple of years, in 10 to 15 years from now, they will no longer be productive, most of them, and they will have many chronic diseases. So they basically switch sides from currently being the most important or much of the most important providers of medical care, they will be the recipients of medical care. And from now being the most productive, often the most productive members of society, they will basically depend on retirement benefits. And that change has to be dealt with. If you want to learn what that means, you simply have to look at the country which does have the problem, which you will soon have. If you, for example, look at the United States in 2040 will have the aging problem that we currently have in Germany. What does that mean? Well, in Germany, we spend 40% of wages already, 40% of wages for Social Security, and on top of this come taxes. Now, Germany is a society where there, at least at that point, there is still a fair willingness to come up with this type of a redistribution. But not all countries are prepared for this type of a redistribution. And also we don't know how we proceed with that in the future. I had to fix the biggest deficit of the German sickness funds in history last summer. And I can tell you that is not a pleasant work. It is not a pleasant work to do, because you immediately have to decide, do you cut services? Do you finish certain benefits? Do you underprovide? Should there be more co-payments? Or is there more money coming in from either taxes or Social Security payroll? And I ultimately decided that there's no cuts, and there is, let's say, more Social Security money coming in. So I increased the Social Security rate so that we are now close to 41% from somewhat above 40%. And we also raised taxes for that purpose. But for how many times will I be able to do that? And for how many times will it be possible to do that here in the US? Where the willingness for this type of a redistribution is limited in comparison to what we see in many European countries. But we will move forward, we will basically move forward in 18 years where Japan is currently. And in Japan, the situation is even way beyond what we have in Germany, and the productivity of Japan is already suffering because of the major challenges for the Social Security system in Japan. So we will be where Japan is now, and no one knows where Japan is at that time. So the aging of the society is a major problem, and we are not well prepared. Additionally, what we often under-recognize as a problem, which is at least as big a problem, is that there is a large inequality in the longevity that I have just pointed out. the longevity, which drives the different distribution between old and young, does not really reflect the injustice we have in terms of, let's say, differences in quality of life and life expectancy between the rich and the poor. And in Germany, for example, in Maine, we have a difference between the upper and the lower quintile of almost 9 years. 9 years. If you were able to treat all cases of cancer without side effects, let's entertain this imagination for a moment. For how long, for how much would life expectancy increase? Roughly speaking, 2 years, no more than 2 years. Now, if you put that into perspective with the almost 9 years difference in life expectancy, that shows you how huge an inequality that is. And in women, it is 4.5 years, and Germany is not an outlier, but we see that everywhere. In the US, the differences are even somewhat bigger, and we see the same differences meanwhile also in the Scandinavian countries. In Norway, you see an increase. So while we have to face, let's say, the aging of the baby boomer generation, we also have completely unsolved the problem in life expectancy between rich and poor, even in the most civilized countries. So therefore, evidence-based policy is badly needed, because this is a problem that we have had for decades by now, but it is worsening. It is not becoming better. It is worsening under our eyes. And also, very badly, if you look at what diseases will become more important and what diseases become less important in terms of quality of life and in terms of, let's say, survival. When I started, I was by and large interested in the epidemiology of cardiovascular diseases, stroke, heart attacks, and so forth. That is why I started with Walter Ripple. Nowadays, most cases of cardiovascular diseases, with what we do know in cardiovascular epidemiology, can be prevented. There are studies that show, roughly speaking, that 90% of all deaths in cardiovascular diseases under ideal conditions could be prevented. And we are step by step gaining ground on that issue. So therefore, cardiovascular diseases are on the retreat. Unfortunately, it's a completely different issue when it comes to cancer and dementias. And when it comes to cancer, we, roughly speaking, can, at the very best, prevent 40% of cases. When it comes to dementia, from what we currently know, we can, at the very best, avoid 10% of the cases. What does this mean for policymaking? Well, for policymaking, that means that the majority of the baby boomers will, at some point in their life, because all of the other diseases are outcompeted, suffer from dementia or from cancer. As a good, reflective young person told me when I explained to her this problem, that she basically said, the two most nasty diseases, they will survive, they will end up. So ultimately, we will be faced with the most horrible, with the most difficult to treat, and also from a subjective perspective, often the most quality of life limiting diseases that are left over. That is the fate of most of the baby boomers. And we currently, from the modeling we know, recognize that about 50% of all people who are in that baby boomer generation at some point in their life will develop cancer. And if they live long enough, that is only a matter of how long they will live, 80% at some point may develop cognitive decline or even dementia. So dementia and cancer are the elephants, the two elephants in the room. And from a perspective of cost, we have just visited the Dana-Farber Cancer Institute. If you look at the cost, for example, CAR T-cell therapy, which we are currently only using for a minor amount of, let's say, lymphomas and leukemias, it is very likely that in the near future, we will be able to use CAR T-cell therapy or personalized medicine, either protein-based or immuno-based, we will be able to use them for almost all solid tumors. So that means that you have costs per patient that are anywhere between $200,000 and $400,000. And if you look what that does mean for society, I mean, how many people do you know with little education that even make that income in 10 years? So we would then spend for a treatment of a single disease more than these people earn in 10 years. And if they survive the cancer, the likelihood of them getting dementia at that point is even increasing. For two reasons. First of all, if you don't survive the cancer, there is no way that you can get the dementia. And number two is, if you have had the cancer treatment, that you live long enough, the treatment in itself is a risk factor for later dementia. Because such a treatment typically damages the endothelial cells, it messes with the immune function. All of that is necessary in order to, let's say, be as aggressive as you need to be in order to make a difference there. But this is a risk factor for later development in dementia, both vascular type and Alzheimer type. So therefore, the aging of the population, the baby boomer, is vastly under-recognized. We also have to focus on a problem which we know for many years, but we have never been able to solve. We do know from studies in the US, but also in Germany and many other countries, if the treatment is done in specialized centers, you will see better survival. We know that forever. Still, we do not manage to treat most patients in the specialized centers. So most patients are actually treated outside of these centers. And here, for example, you see a very recent study, which we have done in Germany with sickness fund data. These are the orange bars, and scientific data from the German Society of Cancer Research. These are the blue bars. And on both accounts, you could see in all of the 11 cancers that we analyzed, in 10 of them, there was a clear-cut advantage in terms of mortality, not to speak about quality of life and morbidity in the centers, a clear-cut advantage. Nevertheless, we do not put that into practice. And we could put it into practice in having more certified centers. We could also put it into practice by developing pathways that make sure that outside of the centers, the treatment is organized in the same way as it is provided in the centers. That is another option. But both options we have never taken advantage of. So this is also something, this is ahead of us. We have to do it. And we can see a similar pattern, for example, if you look at the COVID pandemic treatment. In Europe, you can see that, for example, ECMO treatment for interstitial lung disease for COVID, severe COVID, if you looked at the centers and the non-centers, the mortality in the centers was much lower, partially half as low. So you had a mortality in the centers of, let's say, 35 or 40%. You had a mortality of 70% in the non-centers. So a huge difference, even in something as standardized as ECMO treatment. So we do not manage to get the evidence-based treatment in these non-centers. And if you look at the countries, how well they were doing, there's many studies that show the better the policy was aligned with science that was enacted by politics, the lower the mortality was in these countries. And therefore, we see major differences, even with respect to life expectancy during the pandemic years, depending on the quality of the policies. And evidence-based policies were the best way, the most reliable ways in order to improve outcomes. I come back to my initial claim that we have more than one field, not only baby boomer aging, but more than one field where we definitely need to put evidence-based policy making into practice because the gap is widening. And the second field is climate change. And climate change is, from an epidemiological perspective, the most undervalued issue of our time. Because many people, when they hear about climate change, they believe that it's about the environment, that is about living conditions, that is very few people who immediately think of people becoming ill, more other diseases, lower quality of life, lower life expectancy. So all of the standard, let's say, medical outcomes and the outcomes we care about in epidemiology are not immediately reflected if you hear about the challenge of climate change. But all what is bad about climate change is what happens to you, or not all, but I mean what is, for us at least, is what is most important for climate change, or in climate change, is what will happen to mortality and quality of life in human beings. That is all what climate change is about. And we are currently nowhere near a path where we are in a position to control climate change. Roughly speaking, on this, let's say, template, we are moving towards what is called the SSP2 4.5 trajectories, which means we are heading towards a 2 to 3 degree Celsius global warming. That is where we currently are heading, even under the best of modeling circumstances. What does that mean? Well, in climate change, the problem is, like in some diseases, if you, for example, look at a cancer patient, if you treat the cancer patient too late, the tumor is already so advanced that there is a tipping point and you will not be able to save the patient anymore. Metastatic disease will develop, and one day or another, the patient dies. And with climate change, we are in a similar situation. There are tipping points. Once you go beyond that tipping point, the tipping point will move forward and push other tipping points, and you cannot reverse the situation. So these are irreversible damages. And in the 2.2 to 3 degrees Celsius scenario, so let's call this a 2.5 median scenario, there is already 5 tipping points that we will not be able to correct and that we cannot reverse. The first being the Greenland ice sheet is collapsing, and since it is collapsing, basically the level on which the sun reflects the ice is going lower, and the lower it is, the worse the situation is, because a lower level means higher temperature, and higher temperature increases basically the melting, so it's going down again, and then more sun is coming down, so it is basically an irreversible process, and we can model where the tipping point is, at what sea level and at what radiation level we will come at a, let's say, Greenland ice shield, which is not to be supported anymore. And we have already achieved that tipping point now. So it is highly unlikely that we will be able, whatever we do, long-term, to save the Greenland ice shield. And I could now go through all of the remaining 4 tipping points. But all of these tipping points, with the 4 tipping points just mentioned, for example, the sea ice convection in the North Sea, or for example, the West Antarctic ice sheet collapsing, as a matter of fact, all of those we are in a position that it is almost impossible, because we are heading that direction that we will be able to basically prevent the tipping point to be crossed and the situation to move forward. If we wanted to, let's say, at least avoid that further tipping points are arrived at, we must become practical. So it makes no difference to speak about climate change and, let's say, reduction of CO2 or greenhouse emissions in abstract, but we have to come up with evidence-based policies. And the most important evidence-based policies are tracked by what is called the Climate Action Tracker. That is an NGO group of scientists, and they basically have focused on the most important short-term measures we have to take in order to move forward as quick as possible, so to avoid that the tipping points become real. And on that, we would, for example, have to renovate 3 to 5% of buildings per year so that they are not losing energy by heat. We have to come up with zero emissions buildings exclusively. We have to practice best practice in agriculture, come to that in a moment. We have to stop deforestation. We have to sustain renewable growth as quick as possible, come to that in a moment. No new power plants. Last fossil fuel cards should be sold before 2035. And we need new industrial installations for low carbon after 2020. I also come back to that point in a moment. But if you want to look where countries currently are, you simply have to follow the climate action tracker, and there you can basically get real and see where countries currently are. And no country currently, I think except for Morocco, as a matter of fact, but all other countries, if I'm not mistaken, Morocco is the only country which is on track here. All other countries are not on track, specifically speaking. So everyone is in favor of saving the climate. Everyone is in favor of lowering greenhouse reductions. Everyone knows roughly what is needed. But when it comes to making a difference, we need evidence-based policies. And these evidence-based policies can be derived from such measures. And if it doesn't work, the health impacts, and that is a very important topic for clinical epidemiologists and epidemiologists, they are also vastly under-recognized. For example, if the climate changes, we will have extreme weather conditions. We will have extreme droughts, extreme rainfalls. We will have extreme hunger periods and so forth. But in these extreme weather conditions, you will see more injuries, you will see more fatalities, you will see mental health effects. The heat stress immediately lowers the quality of life. If you have a combination of 35 and 70, which is easy to remember as a matter of fact. If there is 35 degrees outside and 70% humidity, human beings essentially do not function anymore, because then you have to use all of your energy basically to cool down your inner organs. So you can basically do nothing but to be your own refrigerator, as a matter of fact. And in many countries, we are approaching days, weeks, and even months where you will have that combination. 35 degrees Celsius and 70% humidity is, and I actually I remember when I was in Texas, I mentioned that before already, some days actually did have that combination. People were then typically saying, well, I wish I had never heard of this place. That was the response. But this is not that is not the type of climate where you can function. So therefore, we will lose a space of, roughly speaking, that currently, depending on how you count, 1 billion people live where you will not be able to live anymore. So these people either lose their livelihoods or they go somewhere else. And same as, for example, with, let's say, diseases that concern the respiratory tract. If you are in such an area, respiratory diseases are very difficult to handle. Waterborne diseases will come. Malnutrition or undernutrition will come back. In this area which I just mentioned, there will be undernutrition, there will be malnutrition. We will have more vector-borne diseases because the ecology is falling into pieces. And obviously, we will have way more conflicts. We will have forced migration because no one can live there anymore. So these are all extremely important topics for young epidemiologists. And I think we care way too little about them. We look at climate change often as doctors or as epidemiologists, as if this was something concerning the environment, but it concerns us. Ultimately, all this is about is how well we will be able to live. And one additional problem which makes this even more important to solve is the major catastrophe is not happening in the countries and the continents where much of the CO2 and the greenhouse gases were released. Europe and also North America, we will suffer from heat impacts not to be underestimated. But in comparison to all other regions, we will do reasonably well. The regions which have done least in order to create the CO2 emissions or the greenhouse emissions will suffer the most. So therefore, we in many ways could sustain our way of life for quite some time, even under the worst of conditions, while the poor countries have little money, have done little to bring this about, and will suffer the most. They have the least to give against this. So this makes the problem even worse. Therefore, for example, the COP27 meeting in Egypt was a complete failure, unfortunately, or a major failure, because there was no agreement how the rich countries are prepared to support the poor countries, because the poor countries, they cannot basically work against climate change. So there is no agreement how we do redistribute the support, given that the jeopardy, the risk, is so one-sidedly divided. This will also create more pandemics. Pandemics are not mandatory. There was the famous epidemiologist Billington who said that outbreaks are mandatory, pandemics are optional. So if you, let's say, manage an outbreak quick enough, then it will not become a pandemic. But the problem is that we will have outbreaks more and more frequently, because the way, let's say, viruses get from one mammal to the next mammal, and us being often the most important mammal, the outbreaks are becoming ever more frequent, because we basically interfere with the living habitat of exactly those vector animals that make it more likely that zoonotic diseases come about. And there is interesting modeling, and here Mark Lipsitch is here today. He is an expert with respect to that, but some of the modeling is really worrisome. If you look at the modeling, how more likely it becomes that zoonotic diseases will happen if you look at climate change. This is really a worrisome development. So we will see way more zoonotic diseases to potentially become pandemics, and point out that 60% of all existing human infectious diseases are of zoonotic origin, and 75% of emerging human infectious diseases currently do have an animal origin. So we expect more zoonotic diseases to come about, and that will mean also that we expect more pandemics. And we already do see an increase, for example, in dengue fever. We see an increase in the number of months and weeks where malaria can be transmitted. So the tropic diseases are moving upwards, are moving towards the north, and this is also something for which we are not really well prepared. Also, I talked about hunger and undernutrition, and it is little known, but an important issue, that most of the land we could currently use for nutrition, we actually use for animal feed. And only 14% are used for direct food production. So we even use more of our land for fuels. We almost use as much land for textile production than we use for food. So therefore, from, let's say, a production perspective, hunger in our days is exclusively man-made. There is no need that anyone needs to be hungry nowadays. And we have to therefore think, what is the role of epidemiology to help this situation? And one important issue is here that very often promoting plant-based diets reduces not only greenhouse emissions, but at the same time, it also reduces health-related risks. This important study done by colleagues here at Harvard, Musikus and others, shows that basically risk reduction for cardiovascular diseases goes in parallel with the CO2 production which is needed in order to make this nutrition available. So you could at the same time make people more healthy and reduce greenhouse gases, greenhouse emissions. And we have to make this way more known, and we have to work basically towards policy measures, because what I'm showing here are studies that are not controversial. This is known, but we have to come up with policy measures to make that possible. I come to the third part where I believe that, let's say, epidemiology as a key science will have to help the environmental health. When it comes to environmental health, very few people, if you ask policymakers, for example, and very often even, let's say, intellectual people, well-educated people who are not epidemiologists, even doctors very often do not know that, but let's say air pollution, I'm not speaking about smoking here, but simple air pollution, in particular O3 and fine particles, in particular 2.5 particles, micrometer particles. They are the biggest risk factor, environmental risk factors for cardiovascular diseases, but also for diabetes and for cancer. And if you look at the diseases which depend on fine particles and which depend on nitric oxide is a major risk factor for stroke development, cardiovascular diseases, and also for pulmonary diseases. All of these outcomes are also outcomes driven by 2.5 micrometer particles, but 2.5 micrometer particles are also major risk factors for type 2 diabetes and for dementia, both of the Alzheimer type and the non-Alzheimer type. So therefore, this type of air pollution is a major driver of quality of life and survival. And here again, you see what I described before. Once again, you see that most of the damage happens in the poorest countries. And these poor countries, they have little alternatives and very little knowledge about these risks. So therefore, in terms of, let's say, evidence-based policy making, we could save millions of lives if we were to make that knowledge more available and to provide alternatives. To give you a very simple example, one of the major drivers of, let's say, fine particle-derived cardiovascular diseases in Africa is cooking with wood. And if that cooking was done with electrical sources, then many of those patients would simply never develop the disease. So therefore, this is a very simple measure to make a difference. And we need evidence-based policies that make this possible. If you look at the silent killer air pollution, you recognize in the dark blue colors that, again, most of the share of deaths attributed to air pollution from outdoor and indoor sources is in the poorer countries. So if we work as epidemiologists and policymakers to help that to be overcome, these are not expensive investments. It is simply putting knowledge into practice. And there's other areas where we do not even do much research. For example, the extreme loss of biodiversity, the mass extinction. Let's say, animal epidemiologists and researchers, they speak about the 6th mass extinction, as a matter of fact. We are losing species on an almost 3-monthly basis. And currently, we have no idea what this loss of biodiversity is doing for us in terms of more zoonotic diseases coming around, what this will do for the food chain, what other diseases will come around. So in that field, there isn't much research even. And when it comes to polluting our Earth, for example, plastic in the ocean, there appears to be an exponential growth of plastic in the ocean, of which we know very little. We have very little knowledge what this means in the long run. There is microplastics now as part of the food chain. We have found them almost everyone in drinking water, in salt, and in beer, and in the soil. And this topic only in Germany became, let's say, well acknowledged, and there was, let's say, a public discussed about the problem when it was recognized that it is also in the beer, that it is in everything else, makes no difference. But once it was clear it is in the beer, it was a political issue, and so therefore, if in office I address this issue, I already do know in what way I will lobby for even an expensive solution here. So, summing up here, we have to look at what we are doing more and more in the fashion of recognizing that we are in a one health situation. Environmental health, human health, animal health, it all plays together in one health. This is one of the reasons why I think that WHO is really doing a terrific job, a wonderful job in focusing whatever is done on the One Health perspective. And I will give finally a couple of examples what we are doing, because we're giving here a long lecture without mentioning anything that we are doing. You may ask, well, why is the guy telling all of this? What is he doing other than making things worse? So I'll give a couple of examples. For example, we very early on recognized that worldwide there is very little pandemic control. If you look at the institutions that were responsible formally for pandemic control, typically with very fancy names and acronyms, if you look at these institutions, for example, in the year 2019 or 2018, then you wonder how COVID could ever manage to become prevalent or pandemic, because we have so many institutions. But if you then look more closely how many people are working for these institutions, what is their training, how are they financed, where are they located, what is their technical skill, then you wonder why COVID didn't come earlier, as a matter of fact. So therefore, as a G7 group, we agreed, advised by a number of, let's say, eminent scientists, worldwide eminent scientists, we came up with a program that we want to come up with a pandemic. We created a pandemic fund, which will give money into countries, in particular poorer countries, that educate a workforce for pandemic control and also provide resources for surveillance in order to control pandemics. And this pandemic fund, which is organized by the World Bank, came about as a result of evidence-based policymaking. So researchers advised us there what is to be done, and now we have this G7 organized, World Bank administered pandemic fund, which will support poorer countries in particular, but not only poorer countries, to be better at surveillance and to also be better at, let's say, workforce education. And Mark Lipsitch, who is here today, was one of the experts advising us here. So we took basically this evidence-based advice and created something in terms of better policy. I bring a second example. What we organized when I entered office, we organized 16 researchers, very well-known researchers in Germany, epidemiologists, clinicians, virologists, and also communication experts, and they advise me on an almost 2-weekly basis for all I do in, let's say, COVID control. So whenever I have a question, for example, what do we think about the new variant B21, or what is the best vaccination protocol, or what is to be expected in terms of, let's say, Paxlovid treatment and so forth, I meet with these experts and they advise me directly, and also the Chancellery. And when we need written advice, then they come up with a written statement. So they have been doing this for a full year, and I rely on their expertise, and we also make their expertise and their recommendations public. So therefore, ordinary people, but also, let's say, other politicians, they can then recognize or they can criticize if I follow the advice of my own experts or if I'm doing something else. So therefore, I want to be as transparent with this advice as possible. And something similar is done with the SAGE group in the UK, but it works very well, and we will continue this for other policy issues. We have also done something similar for, let's say, hospital reform, and we currently make a major hospital reform. I have already mentioned that we are using the DRG system, but we want to basically create an environment, a policy environment, also a payment environment, where the best hospitals treat the most complicated cases, and where there is less of an incentive to follow the money and more to follow evidence-based guidelines, what needs to be done. So in order to come up with such a major reform, a hospital reform will be the biggest hospital reform that Germany has undertaken in 20 years. I have also organized a group of 17 experts. They have met more than 50 times already, and they just last week came up with a memorandum, 50-page strong, where they develop their views as to how we can go about that issue. And I have promised I will follow that recommendation. So I want to continue to live up to the promise that, let's say, I want to put evidence-based medicine and knowledge from epidemiology, wherever possible, into policies and into politics. Let me finish up with a key insight which, let's say, I have had over the last decades. I really think that epidemiology, and this is also why I was so honored to be asked to basically give the Qatar lecture. I truly believe that epidemiology is a key science for the problems that we are facing. It is a key science for dealing with the aging population. It's a key science for dealing with climate change. It is a key science for solving the environmental issues that I've basically shown. So therefore, I don't know, I'm sure that here is not only epidemiologists, but epidemiology is a key science for what we do. And we also need many health policy experts because, in my opinion, health policy expertise and epidemiology, these are twin sciences in order to make a better world. Thank you for the attention.